Welcome to PerfectServe's Thought Leadership webinar series. I'm Leanne Myers, Chief Clinical Officer at PerfectServe, and I'm joined here with Wendy Barnum, and we are pleased to sponsor today's webinar on how hardwiring culture change. Before we turn things over to our guest expert today, I would like to take a few minutes just to introduce you to PerfectServe. Research has shown that communication breakdown is the primary contributor to delays in treatment. This is because status quo tools and technologies fail to address the complexity inherent in today's clinical communication processes. PerfectServe Synchrony enables healthcare organizations to effectively address the widest variety of communication-driven workflow challenges across all stakeholders. This communication and collaboration platform unites physicians, nurses, and other care team members across the continuum and facilitates timely interaction among them. Now communication can be streamlined, reliable, and efficient, uniting all care team members and the communication technologies they employ across all of their organizations they work with within a single comprehensive solution. We invite you to learn more about PerfectServe Synchrony and how it meets the challenges associated with medical communities head-on. At this time, I'm very pleased to introduce today's guest expert, who's going to share best practices and proven strategies for improved collaboration within your care team. Doug Bonnicum is Vice President, Quality, Safety, and Resource Management for Kaiser Permanente. He has been with the organization since 1994, and in addition to his role with Kaiser Permanente, Doug serves on the Board of Directors for the National Patient Safety Foundation, as faculty for the Institute for Healthcare Improvement Patient Safety Executive Program, and as an advisor to ECRI's Patient Safety Office Program. In 2013, he was named one of the 50 experts leading in the field of patient safety by Becker's Hospital Review. We had Doug with us probably about 6 months ago now for a great webinar, and we're glad to have him back, being able to share a lot of additional information on the topic. Thank you for joining us today, Doug, and I will now turn things over to you.
Thank you, Wendy, and welcome everyone. Let me start with a story, and this comes from the New England Journal of Medicine. In 2010, the journal ran a case study of a 65-year-old Spanish-speaking patient at Mass General who suffered a wrong procedure event. She was admitted and consented for release of a trigger finger of the left ring finger, but instead a carpal tunnel release procedure was done. The orthopedic surgeon who described the case in the journal noted a number of issues which may have contributed to the adverse outcome, including the following. He was asked to translate for her during the pre-op prep phase, as no Spanish-speaking translator was available at the time. According to the hospital protocol, the patient's arm was marked at the wrist, but not at the planned incision site. The site marking was actually removed by the solution used to prep the site, and no formal timeout was done because the circulator mistook the physician speaking to the patient in Spanish as his timeout. Regardless of the outcome, I think you'd all agree that the situation did not sound safe and reliable. And yet, as I read the article, I remember thinking that this was probably not the first time that no formal timeout was not done, or a site marking was inadvertently removed, or someone was translating that should not have been. Today's discussion is going to describe why it's so difficult to implement and sustain safe practice over time, identify the role of leadership in ensuring safe and reliable practice, and describe a model that may be useful in implementing and sustaining practice change over time. After publishing his landmark article entitled The Nature of Adverse Events in Hospitalized Patients in 1991, in which he was overwhelmed by the frequency and severity of preventable harm in hospitalized patients, Lucian Leap took some time to better understand human error and learn what other high-reliability organizations were doing to combat it. After studying the problem, he wrote an article in 1994 entitled Error in Medicine, in which he concluded, quote, "While the proximal error leading to an accident is usually a human error, the causes of that error are often well beyond the individual's control." He went on to say, the important point is that successful accident prevention efforts must focus on root causes, system errors in design and implementation. Using research which included Leap's, the Institute of Medicine published its famous To Err is Human report in 1999, concluding that between 44,000 and 98,000 people went into U.S. hospitals each year alone and didn't come out alive, and it wasn't just because they were sick. If you fast forward that to 2013, a report in the Journal of Patient Safety appears, and it notes the numbers could even be much higher, perhaps as high as between 210 and 440,000 patients each year going into hospitals and suffering some type of preventable harm which contributed to their death. This prompted a neurosurgeon in the Los Angeles area to write an editorial in the Los Angeles Times, a physician named Philip Levitt, who had been a chief of staff at 2 LA hospitals. And he said he knew exactly what the problem was. And I'm reading a quote from his article. Most preventable mishaps in hospitals, he said, are caused by the acts of individual practitioners, not flawed systems. He said the most significant source of patient harm is incompetent doctors. So that was his assertion after all of this work. So here we are in 2015, faced with a problem that may be 4 times larger than we initially thought, and we've seemingly made little progress to stem that tide. So I'd like to open up the poll here in a minute. We're going to have 3 polling questions throughout today, and there'll also be some time at the end for you to ask questions. I think many of us feel like errors in design and implementation are still a big issue, but I'm interested in what you think about the assertion around incompetence, particularly in the context of these seemingly other intractable problems that are on your screen. Let's take a quick poll of what you think the #1 problem in patient safety is today, or at least the #1 problem of the 5 I've listed here. The poll will be open for about 30 seconds, and then it'll take 20 seconds or so to produce the results. So please take a chance to fill out your answers. All right. Well, it looks like very few people agree with Dr. Philip Levitt that the #1 problem that we have to solve is physician incompetence, and I'm glad to absolutely hear that. Lack of teamwork at 6% and lack of accountability at 3%. The absence of a safety culture, I think there's a growing sort of recognition that we still haven't cracked that nut. Here, sort of the #1 problem is a breakdown in communication. And I absolutely think all of these are critically important, and with the exception of the first one, which I really feel like we're well beyond that issue. Let me say this. I wasn't quite sure what your answers were going to be, and I heard that once a good trial lawyer doesn't ask a question he doesn't know the answer to, but I have to admit I had no idea what your response was going to be. I'm just thrilled that it's not incompetence and that you're much more aware of the other issues that we've got. Nevertheless, I feel like I can tie all of the other 4 answers to this notion of accountability, and that's where I want to spend a few more moments on to set the foundation for the dialogue that's going to come later in the presentation. So I want you to think about your driving habits for a moment, and if that makes you a little bit uncomfortable, you can think about mine. So I live 5 minutes off of Highway 580 here in beautiful Oakland, California, and here is what I did on my way to work today. I get on Highway 580 for 2 exits. It's about a minute and a half of highway driving, and as soon as I get on the highway, I set my speed control to 72 in a 65-mile-an-hour speed zone. As I said before, I'm an engineer, and as an engineer, I am aware that engines at idle are inefficient, and I'm also an environmentalist. So when I come to stop signs in the interest of efficiency of the fuel and of the environment, I do what's called here a California rolling stop, where I glance left and I glance right, but I never actually come to a complete stop. At red lights, I clearly stop at those, but yellow to me means one thing and one thing only, and that is actually to accelerate through the yellow light. I don't call anyone on my cell phone while I'm driving, but clearly if someone calls me, I glance down, and depending on if I recognize the number or not, I may pick up. And I actually listen to 2 radio stations in the 5 minutes of my drive while I'm drinking a cup of coffee. So the question could be, am I a bad person? And we actually don't know each other well enough for any of you to come to that conclusion yet. But you maybe could ask a better question, which is, am I a safe driver? And the answer would be no. What those practices that I'm demonstrating every single day are not safe, and they're not that different than many of the other people on the road. Perhaps you demonstrated one or more of those on your way to work today. So what produces these kind of behaviors? There's some work by a gentleman named Jeremy Williams who talks about violation-producing conditions, and he says it's 7 things. One is there's a perceived low likelihood of detection, meaning you're not going to get caught. And I know now from living here for 20 years, if I drive 72 in a 65-mile-an-hour zone on Highway 580, I won't get caught. I have 20 years of data on that. Number 2 is inconvenience, and that's a way of saying stopping at a stop sign at 6 a.m. in the morning when there's no one else around is really inconvenient, and if you make things inconvenient for people, they're probably going to break the rule. Number 3 is a misperception or a lack of recognition of risk. And in my case, the last time I was in an automobile accident was in 1983, and I was rear-ended at a stop sign that I had come to a complete stop at. So I have a complete and absent lack of an appreciation of risk. The next one is an authority or status to violate, meaning that you sort of earn the right to drive poorly over time. Many of you may have children that are of driving age, and clearly if they exhibited any one or more of the behaviors I talked about, you may be taking the keys away from them or at least having a conversation with them. And yet we sort of think because we've been driving so many years that we can drive that way. And the last 3 are around copying behavior and group pressure, meaning we see others doing the same thing on the road and we feel the pressure from what they're doing, and that there's no disapproving authority figure present. And the way I jokingly talk about that is that my mother's no longer sitting next to me in the driver's seat. So those conditions actually set us up to sort of depart from safe practice. I want to take that one step further. Clearly the stakes of poor driving habits can be significant. But maybe the stakes are even more significant in things like you see here on the screen. In describing the Challenger explosion, author Diane Vaughn said, they redefined evidence that deviated from an acceptable standard so that it became the standard. Let me just read that one more time. They redefined evidence that deviated from an acceptable standard so that it became the standard. Normalization of deviance is described as a long-term phenomena in which individuals or teams repeatedly get away with a deviance from established standards until their thought process is dominated by the following logic. Repeated success in accepting deviance from established standards implies future success. Over time, the individual or team fails to see their action as deviant, and normalization of deviance then leads to predictable surprises, which are invariably disastrous to the team and to others. 6 months prior to the Challenger disaster, as some of you know, a NASA contractor wrote, "It is my honest and very real fear that if we do not take immediate action to solve the problem with the O-ring having the #1 priority, then we stand in jeopardy of losing a flight along with all of the launch pad facilities." I have to think that someone in the OR story we began this session with had very honest and real fears months before the wrong procedure was done on the Spanish-speaking patient. But the team slowly fell into the trap of believing their repeated success in accepting deviance implied future success. And unfortunately for the patient and the team, they were wrong. Rene Almoberti has written extensively on this topic, and he says this: violations set in slowly over time, with operators becoming gradually more lax in their performance. This normalization of deviance is maintained by structural secrecy, the absence of incidents, and the tolerance and absence of reaction of senior management. I think Almoberti, like Lucian Leap, believes the system is largely the key, but with the system very much including management's tolerance and absence of reaction to bad behavior. And that's what we're going to largely spend our time on today. A colleague of Almoberti's named Rasmussen emphasized that frontline workers do not follow procedures in a strict and logical manner, but try to follow the path that seems most useful and productive at the time. Workers, he said, operate within an envelope of possible actions, which is influenced all the time by wider organizational and social forces. He described the pressure on individuals and systems to move closer to the boundaries of safe operation. Furthermore, he says these violations become more frequent and severe over time, so the whole system migrates to the boundaries of safety until an accident or some significant recalibration occurs. These external pressures, coupled with individual rewards and benefits, may over time modify the work being carried out, lead to rules and recommendations being progressively ignored, and eventually greatly increase the possibility of disaster as the organization becomes accustomed to operating at the margins of safety. So Alma Birdie took Rasmussen's work and conceptualized it with this graphic, adding the concept of borderline tolerated conditions of use, which meant that as the system migrated from the sort of always into the always sometimes, or what he would call the legal into the illegal normal, behaviors and choices were viewed as providing management and individuals with the maximum benefit for the minimum and accepted probability of harm, with the social context being one that is somewhat independent of rules and procedures envisioned by the designers of the system. And I think when I talked about my driving habits earlier today, I'm hoping many of you would agree it's not sort of in that illegal space. I'm not flying down the highway at 120 miles an hour, recklessly and negligently driving, but it's clearly not the always space that my son Liam, who's in the process of getting his permit right now, is in. I've migrated into this sort of illegal normal space. And again, not pointing fingers at anyone else, but I'm not the only driver on the road behaving that way. And the fact is, once we come to work, it's really hard to sort of park those practices at the door and then become completely tolerant and observant of all behavior. So what I've come to believe after being in this organization for 20 years, and I work here at Kaiser Permanente, we cover 10 million lives in the United States. We're an integrated delivery system, both an insurer and a health plan provider. And with 10 million lives, you can imagine that occasionally we do harm. And I sit in a national office where I view all of the medical malpractice cases that happen and all of the sentinel events that happen across the program. And here's my conclusion on the slide, that most adverse outcomes are not caused by simple human error, nor are they caused by willful violations of available, intelligible, workable, and correct procedures to the point of gross negligence or recklessness. But it's some combination of error and drift, that normalization of deviance that we talked about before, where the staff member was following a path that seemed most useful or productive at the time, and in the aftermath of the adverse outcome, now we know that it wasn't. So we're going to go back to a polling question here in a second. Let me just pause for a minute before we open it up and say, one way I think to address this notion of drift or normalization of deviance is having our own profession unblinkingly deem some behaviors as unacceptable with clear consequences to serve as a vivid example of our professionalism. This concept was developed in an article by Bob Wachter and Peter Pronovost in 2009. The article's title was Balancing No Blame with Accountability in Patient Safety. I want you to read the poll question here. We'll open up the polls. It'll be open for about 30 seconds and see whether you agree or disagree with the assertion of Wachter and Pronovost around accountability. Okay, and it'll take about 15 seconds or so to see the results. With, again, the question being, having our own profession unblinkingly deem some behaviors as unacceptable with clear consequences will serve as a vivid example of our professionalism. But the main reason to find the right balance between no blame and individual accountability is that doing so will save lives. Let's see what you thought. Okay, interesting. 98% of you agreed with that assertion. Well, I'll tell you what's interesting. Last year at the National Patient Safety Foundation Congress, this concept was actually debated as part of a plenary. One of the plenary speakers was Bob Wachter from UCSF, debated Dr. Greg Meyer from Mass General, and they were each asked to take a side. One side on this notion of that part of our significant problem is that we don't hold people accountable, and the other side being if we rush down this road, we can squelch all of all of the reporting that we need to occur. We can have people not share information that needs to be shared. We can basically go back to a culture of silence, and that it's too early to go down this accountability path. It turns out, much like you, the audience of 1,000 people at that Congress agreed it was time to raise the bar on accountability. It turned out there about 80% of the audience agreed with that point. Today, we've got 98% of you talking about this as well. Now, I generally believe that to be true, too. But I feel we need to first look in the mirror and reflect on our own accountability before we set off trying to hold others accountable. And I really love this quote from David Marks on this next slide. David Marks, you might recall, is the founding father of the just culture algorithm, him and Jim Reason. And David said this in an interview: when it comes to shaping on-the-job performance, there are two things that leaders can influence: the design of work processes staff use and the behavioral choices they make to accomplish their work. Both affect safety. And I think what he meant by that is both affect both patient and worker safety. So it's up to the leader to work with the team, I think what he's telling us, to design workflows that work for the worker, and to also shape people's choices, the choices that they're going to make. Ultimately, they're accountable for the quality of the choice they make, but that the leader's role has to be in shaping those choices. Now, when I think about shaping on-the-job performance, the accountability I'm much more comfortable with is the design piece of Marx's statement. My background's in chemical engineering. I was in the U.S. Nuclear submarine force for a number of years. I feel very comfortable in the engineering space. I know exactly how to prevent the particular problem described on this slide, which is a worker injury in this case. And it has nothing to do with our typical response to such problems as changing a policy or providing some education or maybe even administering discipline, holding the individual accountable basically for cutting their finger off. This type of problem, to me, clearly requires an engineering control, a machine guard to never allow this to again happen to any worker. It's not about sort of admonishing a worker or telling them to follow safe protocol. It's about designing that hazard out of the environment. And again, as an engineer, I feel very comfortable sort of in that space. The model we use here at Kaiser Permanente is called the hierarchy of controls. It's based on a Toyota production process model called Poka-yoke. I may be saying that incorrectly for those who are familiar with that term, but Poka-yoke has three fundamental concepts. One is to eliminate a hazard that can be eliminated. If you can't do that, you facilitate, which for me translates to making it really hard to do the wrong thing and making it easy to do the right thing. And then finally, this concept of mitigation, which means some things are going to slip through the cracks, so you need to have systems to be able to detect that which slips through in a way that harm is minimized to the patient. And we've conceptualized that in this model here, which really works very, very well when there's a hazard that can be physically designed out of a system or mitigated in such a way that if harm occurs, it's less consequential. Controlling sort of hazards and precursors of harm using something like the hierarchy of controls in an engineering approach is one thing, but getting a busy practitioner to reliably wash in and wash out or do a timeout with the spirit and the intent of which it is meant, that's quite another challenge, and it's a challenge we continue to face today. And more challenging still is to get staff to really feel like they're 200% accountable for safety. And what I mean by that is that they're 100% accountable for the quality of choices they themselves make and 100% accountable for ensuring their teammates make the safe and reliable choice as well in the interest of the patient's safety. So the broader challenge I think we faced 15 years after There Is Human was named this way by someone you're all probably familiar with, Atul Gawande. And he said that the challenge really isn't how to keep bad physicians from harming patients, so he would vehemently disagree with Dr. Levitt. He says it's how to keep good physicians from harming patients. And I would broaden that a bit. I would add the challenge isn't how to keep bad physicians from harming patients. I would add bad pharmacists, bad nurses, bad technicians. It's really how to keep good pharmacists, good nurses, good technicians, good physicians, good administrators from harming patients. So that is the challenge that we face. Now, the model that I'm going to share with you here is based on a number of other models that are available in the literature and that you may be very familiar with as well. Basically, starting with sort of adult learning theory and experiential learning, meaning that we as adults much prefer to have hands-on and to get feedback if we're going to learn something and do it reliably than we do with a piece of paper and a test that comes afterwards. Another model that influenced sort of the design of what we'll share with you here in a minute is called the influencer model by a group called Vital Smarts, and has a lot to do with trying to examine individual skill and will and team skill and will in order to create sustainable change. I'm also pulling from those violation-producing conditions that I talked about before. The person who came up with those was a guy named Jeremy Williams. He's an ergonomist. His work appears in a book by Jim Reason, but it's around sort of what causes me every single day or what contributes to my driving habits, and how do I address those conditions in a way that actually gets the right outcome as opposed to the wrong outcome. And then finally, behavior-based safety models such as that developed by Tom Krause, and even service excellence models such as that designed by the Studer Group. All of these things, when you take a step back and look at them, have common threads throughout. And I've just tried to conceptualize them in a way that works, I think, for the type of behavior change that we're up against in healthcare today. Before I share the model, here's my disclosure statement. All models are wrong and some are useful. And I hope this one will be useful for you. So let's take a look at it. I called it hardwiring the soft stuff initially, and by soft stuff I really did mean behavior and practice changes. And someone at one point came up and said, you know what, you need to rename that model because it's the practice changes and the behavior changes that really is the hard stuff. The engineering controls, the system fixes that Lucian Leap had envisioned, that's the easy stuff. Getting people to take 100% accountability for their own behavior and then 100% accountability for making sure that their teammates do what they're supposed to do, that's really, really difficult. So we renamed the model and we put it in the form of stairs, both to imply that there is some sort of natural progression of the steps that I'm going to describe, but also to say taking the stairs is really, really hard work. So there's I think there's a reason that this stuff doesn't get done, because in order to do it well, it takes an incredible investment in management's part in particular. So let's take a look at each of the steps here separately. So the first step is socialization. And let me just read this and then make a few comments. Socialize the issue at hand for the primary purpose of increasing stakeholder knowledge, identifying what's currently working and what's not, and creating the will for change. The team must understand why the issue is important, and in particular, why the issue is important to them in the context of their work. So I said before, my background, I was a chemical engineer, and then I joined the submarine force for 8 years. And the one question I don't think I ever asked in the Navy was why. If you asked me to jump, I would just ask you how high or what type of jump would you like me to do, but I didn't ask why. I followed orders and I gave orders, and I recognized that primarily was my role. That's not to say we didn't have a flattened hierarchy where people could raise concerns and ask questions, but the what's in it for me concept really wasn't part of our fabric. And yet what I recognized when I came to healthcare is that that's very important. That physicians, pharmacists, nurses need to know what's in it for me, not necessarily in a self-serving way, but in a way that's going to enable me to support my patients. So how is this going to help me support my patients? Why is critically important to explaining to get people on board. And I think one of the biggest steps we miss in our organization, even though we're not command and control, is to take time to socialize the issue, to really meet people where they're at, to explain why the current way that we're doing business is not acceptable, and to create sort of a will to change. And that is the first step. So socialization really means why, and it means in particular what's in it for me in the practice of which I am currently performing, and a critical step to sort of starting this behavior change process that we're talking about. Let me stop and just say, if you've got questions, again, you can write those into the chat box, and we will address all of the questions at the end, because there should be time for that. So as we're going throughout here, if you've got certain reflections or you just want to make an observation, please share that. All right, the second step is around standardization. That was a term that was extremely familiar to me in the Navy, and very foreign when I first came here to Kaiser Permanente, and I think to healthcare in general. Much more sort of embraced today than it was 20 years ago, although I still think as an industry, healthcare has a long way to go here. So the second step to hardwiring hard stuff, after the issue's been socialized and people are on board with why there's a need for a practice change, is change to what? And it's the standardization step. It's to create a team, and it's really engaging the team of the people that you're asking to change, and to standardize a change that is going to result in an improvement. The why behind standardization was explained once by a physician at Intermountain Health named Brent James. He was talking to a group of cardiologists, I think, at the time, and he said, "Doctors, I'd rather have you do it the same way than do it right." And there was a sort of a big pregnant pause, and you could hear sort of people shuffling and not believing what he was saying. And he said, what I mean is you're all pretty much right. You're all well-trained, you're well-educated, you've got a ton of experience, so you're all pretty much right. But unless we do it the same way, it's going to be really hard to orient new staff. It's going to be hard to know which way is best, and it's absolutely going to be hard to improve over time. So I don't know how you should do this. You're, in the specialty you're in, you figure it out, but let's standardize it for those purposes. And that's what this slide basically describes, is to embrace a team in standardization, first by explaining why standardization is important, and then having them actually do the standardization, but for the purposes of orienting and training new staff, really knowing which way is best, and then being able to improve off of that standardized process over time. And again, I would say this is a significant opportunity in healthcare, although we've made great strides over the past 15 years or so. All right, those are the first two steps. The next step, again, I think is mission critical, and this takes time, and it can take money and resources, and that's demonstration. So I think healthcare is very comfortable with education, which typically means some short little briefing or a piece of paper that someone reads and then signs and is put in their record. So if they sort of cross the line, someone can say that they've been educated. But we don't necessarily spend enough time on demonstration. And that is actually providing each affected individual an opportunity to practice the new change, the new behavior, in a safe environment. That is to demonstrate their ability, not just their knowledge, to do what is being asked in the way that it is being asked to be done. I think one of the things that we face in healthcare as a barrier to this is that people are so smart and they're so passionate about what they do that we just figure they can do these simple things. And we don't take time to show people actually exactly how we want them to wash their hands, or exactly how to mark a surgical site, or exactly how to do an independent double check of a high alert medication, because we just assume by giving them some education and something to read and having them sign off that's sufficient. And what I absolutely learned from my military experience is that's not anywhere close to sufficient. That if you want people to do something in an operating environment, you've got to give them the ability to practice and get some feedback in a safe environment. And in this case, simulation of multiple sorts works here. And what I meant by that is high-fidelity simulation, that it can include things with mannequins and videotape recording and immediate feedback, or low-fidelity, which just might be a tabletop-type exercise. But it's absolutely critical to hardwiring the behavior change that we want to see in healthcare. This next step, step 4, is sort of a catch-all, and it's really implementation, and that's to say, even for small behavior and practice changes that we want, you need some sort of project plan and typically some type of project manager who's going to make sure that they solicit the right sponsorship and they get champions, that there's budget to do the demonstration that we just talked about, that there's a certain timeline, how much by when, that there may be policies that need to be adjusted, and we'll do that at the appropriate time, that there's broad communications about the why and the when of the change, and that there's actually some monitoring strategy in place that goes on for, as long as it needs to make sure that the practice is actually hardwired. I think one of the things that we've been tripped up on in healthcare from time to time is some of the Joint Commission requirements, which in the aftermath of an adverse outcome, when you have to do a root cause analysis, they say basically you should have your monitoring plan in effect for 90 days or 3 months. And so, come day 91, we stop monitoring typically. And I think that is not always the prudent thing to do. So part of sustainability is having a smart implementation plan, and part of that is to have a smart monitoring plan as well. I would just get you to be reflecting on every step that we've talked about so far is really a step that managers and leaders need to take. They're the ones who are responsible for socializing the issue. They're the ones who are responsible for giving staff space to standardize what needs to be standardized. They're the ones who need to provide an opportunity for demonstration. They're the ones that need to provide the funding, the sponsorship, and the plans for implementation. And they are absolutely critical on this next step, which is around observation and coaching. So just going back to Atul Gawande again, he wrote an article in the New Yorker where he said he had gotten to a point in his surgical career where he knew his performance was not going to get any better and it could probably only get worse. And he thought about all of the coaching that goes on in the United States today. Many of you may have a coach because you want to get your golf game from a score of 105 down to, you want to break 100. Or that you have children who you'll get coaches for playing baseball or doing a musical instrument or acting. We invest an incredible amount of resources coaching for executives. And yet the one group that we don't provide coaching to are physicians and nurses unless they've been involved in a catastrophic outcome. And that's the worst time for anyone to be coached. So he wrote an article about bringing an old mentor of his back into the OR and having the mentor observe and then debrief afterwards, and just how much he learned in that process. Well, I'm making an assertion here that observation and coaching process is not sort of a once-in-a-lifetime thing, but it has to be a continual part of what the middle manager in an organization does if you want to hardwire a behavior change. And in this case, we say observe the behavior and practice change in real time. It's informal and undocumented, so this is not sort of an HR observation process. It's to recognize those that are doing the new practice well and to making course corrections through good, honest coaching and dialogue for those who aren't. Once the individual skills are validated and the abilities have occurred that you can actually do this practice in an operating environment, then the coaching discussions can transition to focus more on meeting expectations and what the individual needs to do to change. But until that point, it's very much about what the management system can do to support the individual through this practice change. And it's really, really difficult in healthcare to do, but absolutely critical to the success of hardwiring hard stuff. Okay, just 2 more steps, and then we'll have some time for examples in the organization here where we've applied this model, and then open it up for questions and answers. So this next one is equally critical, and it's around conversation. And what I meant by that was really the ability for staff to talk to each other. So we know, for example, in healthcare right now, that when people are watched, and this is sort of industry-wide, when people are watched, their hand hygiene compliance rate may go up to 85, 95%. And that's when someone's in the ward, with a clipboard, actually watching people, and they're very present. We also know through secret shoppers and other mechanisms we use, when the clipboard goes away, often so does the practice, maybe as low as 40 to 50% of the time. My assertion here is that those type of deviations from what we expect, sort of that normalization of deviance, is not happening in a vacuum. It's happening in broad view of everyone else's colleagues, and yet it's very difficult in healthcare for one colleague to address another colleague in the interest of patient or worker safety. So the 6th step to hardwiring behavior change is to more fully develop the expectation and create the climate and continue to nurture staff's ability around the motivation to speak up about the desired behavior. So it's one colleague addressing another colleague. with the thought being in the absence of effective peer control, like if you and me can't talk about the safe practice when our manager's not around or the person with the clipboard's not around, then to quote another phrase, drift happens. And that's exactly, I think, what's going on right now, is that we're having a very difficult time sort of on colleague-to-colleague conversations to keep each other, in the norm. Now, finally, the last step, escalation. So let me read this. Create an escalation policy and procedure or practice, establish an expectations for its use, and provide staff the ability and the motivation to escalate when needed. Individuals should be instructed to assertively voice their concern at least 2 times in most situations. That's called the 2-challenge rule and is discussed extensively in the AHRQ Team Steps program, to ensure that it has been heard and to afford an opportunity for resolution. For behaviors that are unacceptable or responses by those challenged unprofessional, leaders must investigate and then unblinkingly respond with clear consequences. So I use the word back here, unblinkingly, and that's the word that sort of triggered your earlier response in the poll, where 98% of you agreed that we have to address these issues unblinkingly, because it ties back to that quote. But I think the leader really can only not blink in this step when they've taken the first 6 steps. So when we talk about accountability, which I clearly think is sort of at the core of many of our issues, the leaders have to be accountable for socializing, helping to standardize, enable people to demonstrate, have an implementation plan, provide observation and coaching, enable conversation, and then finally, if a person either will not or cannot do the new practice change, that's when escalation becomes critical, and when we have to unblinkingly look at that and say, that's just not the way that we practice around here. And I think what's going on right now in many organizations is that we skip the first 6 steps and we get to that 7th step, and we think about accountability in that context instead of, once again, perhaps looking ourselves in the mirror and asking, what are we accountable for? So let me quickly share 2 processes here in my organization where this model was alive and well. One was called Surgeon as Leader, and it was initiated in our Northwest region up by Portland, Oregon, in their Surgical Services Department. The objective of the program, well, let me just say it was prompted by some safety culture data which would suggest that it was difficult to speak up, to resolve disagreements, and indicated that the teamwork and the safety climate was not nearly as high as we wished for our patients and families. So the objectives of this program were to have surgeons be able to demonstrate communication techniques to foster a climate of teamwork and open communication in the OR, to have surgeons understand the importance of personalizing the surgical patient to the OR team so that it wasn't a kidney case, it was Mrs. Jones, who's a community activist, and let me tell you something about her, and the surgeon would actually have to take the time to do that. To demonstrate the ability to direct and maintain the team's constant focus on safety by flattening the hierarchy and inviting the entire team to have each other's back. And then to ultimately eliminate the occurrence of surgical sentinel events, sort of those never events that we talk about. In addition, at the same time, they were trying to dramatically improve their national surgical quality improvement complication rates. So they took surgeons, they socialized the importance of this. They said, you are indeed the captain of the ship, but unless you flatten the hierarchy and embrace the team, we're not going to get the type of outcomes that we want in terms of eliminating complications. And certainly these never events, which occur periodically, are not going to go away because not everyone's fully vested. They had the surgeons go through a process that was comfortable for them. So they initially provided a model on how to, for example, introduce the patient and how to flatten the hierarchy, and the surgical team got to work on that and standardize it in a way that was comfortable for them. They then invited, initially alone, the surgeons into their simulator. They actually have a simulator in their hospital where the surgeon then would go through sort of their mechanisms of flatten the hierarchy, introducing the patient, getting everyone's focus on safety. And then they recognized that the best way to do this is actually to have the whole team be there with the surgeon and to videotape it and to debrief the entire video tape with the surgeon and the team. They encouraged and empowered team members that if they didn't see the types of behaviors that were being expected, that they should, politely and respectfully remind the surgeon. And if that didn't result in a positive outcome, that they were empowered to escalate that issue up their chain of command. They had the chief of surgery go into the operating room after all of the simulations were done to actually observe the behaviors in real time and then debrief privately with the surgeon afterwards, recognizing and rewarding when it was done remarkably well, and also trying to make some course corrections when it was not. And in one case, they needed to sort of go to that escalation phase where they concluded that an individual either would not or could not embrace this concept, and that that person would need to find somewhere else to work other than in our organization. So it was done remarkably well, and as a result, they dramatically improved their NSQIP scores, their National Surgical Quality Improvement scores, as well as eliminating retained foreign objects and verification events that had occurred previously. And they've been able to do this for about an 18-month period, so I'm confident that it's a sustained practice now. The next one that I just want to briefly talk about is around the use of robotics. And this was introduced in our Southern California region. And again, there was a significant socialization stage. Here, the socialization was if you want to be part of using the robot, and a number of surgeons did, here's the norms and expectations that we're going to expect of you once you come on board, and I'll describe them in a second. So before people got to sort of sign up for this, they had to be socialized to what the new norms were going to be with the use of the robot. One of the norms was going to be that all of the equipment, all the way through the sutures, was going to be standardized, and that each phase of the processes that they were doing was going to be standardized as well, and that the surgeons who were coming on board needed to agree to both using the equipment that had been standardized and the techniques that had been developed in all 5 phases of each of the procedures. They were initially educated and provided some demonstration in a safe simulated environment. And then once sort of the go-live date came, they actually videotaped each of the procedures and were able to look at any complications together after as a team to figure out what went wrong and what needed to be done differently. Early on, groups like environmental services, who were responsible for cleaning the room, were embraced to be part of the team. And not only did the teams huddle at the beginning of the day to talk about their plans and what procedures were going to be done, but they debriefed at the end of the day, including groups like environmental services, by absolutely flattening the hierarchy and giving everyone a chance to speak up. This is sort of along that conversation phase. Now, from what I understand, they've not had to go to the escalation phase because of how much emphasis they put on the first 6. But one thing that I do know is as they're training a new physician, they're given a certain period of time to complete each phase in the process. And if they aren't able to successfully get through one piece of the process, the mentor or the coach steps in, completes the process for him or her, and then returns the instrument back to the surgeon performing the procedure. And then they know then that phase, whatever that step was, is something that needs to be worked on and mentored and coached, and that's where a lot of their energy is further focused. So again, they went through that concept of socialization and standardization, of giving people a chance to practice, of having a chief come into the room and actually watch and then observe and debrief afterwards, of going through videotaping and actually looking at complications as a team in a way that embraced everyone's voice, and on having an escalation process should they need it. We're going to go to our final polling question before we open it up to some more dialogue. And I just want you to sort of reflect on these steps in particular. So I took out the implementation step and the escalation step. And the polling question for you is, which one of these 5 steps do you miss most often in your role as a leader? So if we can open up the poll, maybe several of these, but think about the one that you really feel like your unit, your organization most misses. Is it socialization, standardization, demonstration, observation and coaching, or conversation. And the poll will be open for about another 10 seconds, and then the results will accumulate, and we'll display them for all to see. All right, a pretty good spread, actually. So 17% feel like we don't explain why enough. 21% say we don't really take the time to get the level of specificity we need around the new practice or the new change. 19%, nearly 20% say we don't give people a chance to demonstrate their ability to do it in a safe environment. That would be the simulation thing. 34%, which is what I was guessing, say that we don't observe and coach. So we're really great in healthcare about sending someone out with a clipboard who secretly records data and then brings it back out for some report to be produced. We're really not very good at tapping people on the back saying, you really did this really well, and I noticed when you did this, X, Y, and Z, can we talk about that? And doing constant course correction. So observation and coaching comes up as number one. And then finally, conversation, which again, you'll know whether that's an issue in your organization through safety attitudes data, through cultural surveys, but it still remains a pretty significant challenge in healthcare as well. All right. So I would just ask you, as we're concluding this portion of the presentation, what step might you take as a result of today's discussion? Hopefully there was one or more of those that resonate with you. I would suggest that model is really sort of an all or none. I do fundamentally believe all of those steps need to be taken if you're serious about hardwiring hard stuff, but you have to begin somewhere, and it looks like a number of you might benefit from that concept of observation and coaching. So this is my final slide, and I just wanted to share with you, I'm part of the board of directors at the National Patient Safety Foundation. We've got a vision statement, which is creating a world where patients and those who care for them are free from harm. And I think by applying the techniques that we're talking about today, we will take a significant step in that direction. So thank you, and we are now opening up to questions.
Great. Thank you so much, Doug. At this time, as Doug mentioned, we'd like to allow for audience questions. You can type them into the question and answer box, and we will moderate, and Doug will be answering some questions here in the next 8 minutes or so that we have left. There's already quite a few in the question and answer box, and we will get through as many as we can. So, Doug, the first question is, what are your strategies where folks, quote unquote, just refuse to adopt new change, especially when there's no incentive, especially financial incentive?
Yep. So I think we've been most successful in that area when you have leadership at the right level in the organization, being the person to whom you have the conversation with. So, when I shared with you the surgeon as a leader, it was the chief of general surgery who said, "This is really, really important. It's really, really important to me, and it's really, really important to our patients." And he also recognized it was going to be a journey, right? That it wasn't going to happen overnight, but it was crystal clear in his head that the culture in the OR needed to change if we were going to get better outcomes. And my experience has been when you have leaders at that level in the organization, so you don't need leaders much lower, and you actually don't need leaders much higher. You need levels like leaders at that level in the organization who can embrace the team and go through the why and demand sort of that level of standardization, but give people time in that space, that's the best strategy for addressing those behaviors, because he did have to have what Jerry Hickson at Vanderbilt describes as coffee talks, which begins with things like, can I speak to you for just 2 minutes? I got a report that you X, Y, and Z. I know that's not what you're about, and clearly that's not what we're about here at Vanderbilt or in the Kaiser Permanente Northwest region. So I'm sure that you'll take care of that issue. initially it's that simple. And then what Jerry would say is he just walks away from it. And I think my general surgeon leader in the Northwest region would have done the same thing. Call it to the person's attention, remind them that that's not what they're about and that that's not what the organization's about, and then walk away. And then, the second or the third time you get it, have a more meaningful and deep conversation up to and including if the person, and this is where the will not or cannot, you as an individual either will not or cannot make this practice change, then there's somewhere else that you may want to be working. And I think a couple of difficult conversations like that send a signal throughout the entire enterprise that we're deadly serious about this and that we're going to give you time and space and the resources, but in the end, this is not going to be accepted, and that's where I find it most successful. I think in absence of that, I'm going to call it backbone, you're really going to be challenged.
Great. Thank you very much, Doug. The next question is, in the robotics example, can you give specific examples of how you were able to get physician support and engaged?
Yes. So I would say the key there was that the gentleman who led the program, again, very well respected technically and interpersonally, with a small group of people, said, there's going to be a lot of people who are going to actually want to use this tool, who wouldn't. And yet we have to be really, really careful with the implementation and really mindful of the outcomes that we're getting. We're going to have to really demonstrate that it's value to the organization. So there's going to be some, what I would just call, in the Navy, we would call rules of the road. And those rules are going to be socialized with groups before they get to use the robotics. And I think that's where he was really smart. It was basically having pretty significant dialogues with anyone who signed up and interested about these are the rules of the road. And, this is the rule around the equipment that we're going to use. This is the rule about how long a procedure should take and what's going to happen if you don't get to that. This is the rule around watching your complications on videotape in front of providers and us all talking about it so that we can all learn together. And so it was very, I would say the success there was being explicit up front about what the rules of the road were. And again, coming back to backbone, having the backbone to sustain and implement those rules over time is what I think has made that program successful.
Great. Thanks, Doug. And then I have one more question that I think we should have time for, and it's a comment and a question. I think people usually understand the bigger picture of patient safety, but when bringing new team members on board, it's often hard to create context for them in their day-to-day job. Do you recommend any particular practice to help with this?
So, part of it, and I don't know if this is a great response to that, but part of it is I think that people can relate to their experiences sometimes outside of work. And so even having dialogue about sort of like the driving habit part, I think is sometimes useful. I often engage people with this concept going back to things like the hierarchy of controls that we talked about around how they keep their house safe when little children are in the house, and how they don't use policy and procedure, and they don't do training and inspection, and they don't discipline. What they do are fundamental design changes to keep kids free of harm when they're little, and that is really, really important to take that sort of mindset, successes that you've had somewhere else, and to translate them into our busy practice. So we're not going to tell people to be more mindful and to slow down. We're going to take a step back and really address what the hazards are and approach that in a fundamentally new way. So I think trying to meet people where they don't have that context and they don't have that background is to meet them, with context and background that they do have. And I think, even if you don't have the context and background, I think what we have to do as organizations become much more transparent with our data and information that we do have, and socialize that data and information in a way that a person doesn't have to experience an adverse outcome to know that it happens both in their organization and outside organizations as well. So I would say transparency of data, both inside and outside your organization, combined with meeting people where they are, can be helpful in that regard.
Great, thank you. So, Doug, this brings us right to the top of the hour. I want to thank you for sharing your insight and your expertise with our group today. It's very much appreciated. To our audience, thank you for taking the time. If you would like additional information on how PerfectServe's communication platform can help your hospital, practice, or system streamline communications and improve operational efficiency, let us know using the poll feature located on your screen. If you enjoyed today's webinar, here's a look at our calendar of future events. These webinars are always free, and links to register can be found at PerfectServe.com by clicking on the Knowledge Center tab. Again, Doug, I would like to thank you for sharing your insight and experience with us, and also thank you to our audience for taking time out of your busy day to join us. Please take a moment and tell us how we did, and have a great afternoon.